Okay, so we're going to talk in this section about a few other complications of pregnancy. First, we're going to talk about placental abruption. That's when the placenta separates from the wall of the uterus before delivery. This can happen prenatally. It can happen spontaneously because of some different risk factors. It can happen because of trauma, or it can happen in labor. What are the things that make it more likely? Increased pressure within the uterus. So if you've got more babies than one, if you've got more fluid than there should be, or if you've got increased pressure for some reason. Maternal hypertension, if the mother has increased blood pressure. So remember, our patient with preeclampsia is at risk for placental abruption. Smoking, alcohol, drug abuse, in particular stimulant drugs, increase the risk. Induction of labor because they cause increased contractions. A non-vertex presentation means baby's not head down. Trauma or a sudden change in intrauterine pressure, like with artificial rupture of membranes or the birth of a twin. So if the uterus is, imagine a balloon, and glued to the inside of that balloon is a disc, okay? If that balloon suddenly changes sizes, then where that disc is glued, that may come loose, okay? So think that's what when you're thinking about a sudden decrease in intrauterine pressure. Some signs, what does this look like? This is the most important thing. Pain. It is painful. If they're in labor, they may have pain that remains in between contractions. Pain and contractions should, pain and labor should only be during the contraction. If there's pain between the contractions, there's something else going on. Uterine irritability, if you have them on the monitor, you might see little tiny squiggles at the bottom, like little mini contractions. It's like the uterus doesn't completely relax. And if you palpate, it doesn't feel completely relaxed. They may have vaginal bleeding, but sometimes the bleeding is hidden behind the placenta. So if you have other signs and no bleeding, you should still suspect placental abruption. And then you may see maternal or fetal vital sign changes because the mother can lose too much blood and begin to show signs of shock, or the fetus can lose too much blood and begin to show what we would see in the fetus is changes in the monitor reading, okay, in the monitor strip. Management, if it's a partial abruption and the mother and the fetus are both stable, they may actually just monitor this because sometimes these will, the bleeding will stop on its own and there's enough functional placenta left to continue the pregnancy. A cesarean is done if it's a complete abruption or if either the mother or fetus is unstable. They need to be prepared for massive hemorrhage. Now, in labor, they might attempt, as long as mother and fetus are stable and the bleeding's not too heavy, they might attempt vaginal birth. But if there's any instability or if it appears to be a complete abruption, they're going to do C-section. Complications, the uterine muscle can actually get filled with blood and then it can't contract. And when that happens, after delivery, they will actually exsanguinate. And so that sometimes if they can't get it to contract, they have to do a hysterectomy. An amniotic fluid embolus, when some amniotic fluid gets into the mother's bloodstream, that causes a massive histamine response and can lead to DIC, which is the other complication. So placental abruption is one of the big scaries, and it has some pretty serious complications. Placenta previa is when the placenta is implanted near or over the cervical os. So it's near or over the opening. If the placenta delivers before the infant, then we have maternal and fetal hemorrhage, and the fetus is not getting adequate oxygenation. If it's a partial detachment, we might see some fetal heart rate changes and meconium, but they may still be able to perfuse adequately. So who is more likely to have placenta previa? Multiparity, the more pregnancies they've had, the more likely this is. Increasing age, if they've ever had it before, plus history. Abnormal placental implantation, like accreta, increta, or percreta, which we'll talk about in a bit. Smoking, cocaine, a previous uterine surgery. Most of the time they don't know. It's just by happenstance. It just happens. What does this look like? Vaginal bleeding without pain. Placenta previa is painless because the blood is not collecting behind that placenta and invading the wall of the uterus. Okay. They may have fetal heart rate changes if the bleeding is severe enough. Management, a patient with placenta previa gets 0 vaginal exams. They used to teach us before everyone got ultrasounds that if you do a vaginal exam and you feel something really soft and squishy like hamburger, don't take your hand out, call for help, because that's likely the placenta. And when you remove your hand, you've disrupted blood vessels. When you remove your hand, they can start to bleed. It's unusual to find a placenta previa that way now because most people have ultrasounds and they've been identified. So if the placenta is low-lying, so it's near the bottom, but it's not over the opening, they may actually try to do a vaginal birth. They'll just be monitored more closely. If it's complete, if it's over the os, they're going to have a C-section. They need to be monitored for bleeding and fetal heart rate changes through the end of pregnancy and if they labor at all. Next thing we're going to talk about is hydramnios, also called polyhydramnios. Poly's too much. So this is greater than 2 liters of amniotic fluid. What makes it more likely? Fetal anomalies in particular. If they have anomalies involving the esophagus and they're not swallowing some of that fluid. But there are some other anomalies that can contribute to it or can be a risk factor. Increased blood volume. The mom, sometimes this just happens because there's increased blood, the mom has increased blood volume. Maternal diabetes, RH sensitization. So if there's an incompatibility with blood types and the mother's been exposed to fetal blood and made antibodies, and multiple gestation. So what can go wrong if they have too much amniotic fluid? It can stretch the uterus enough to rupture. It can cause an abruption by stretching the uterus too much. It can lead to cord prolapse because when the water breaks, there's more fluid to kind of gush out quickly and wash the cord out with it. And it can cause the fetus can actually change positions during labor. Okay, so it can allow the fetus to get into weird positions during labor. Management, if it's severe and it's not time for delivery yet, they actually can do an amniocentesis to remove some of the fluid. In labor, they're going to do a slow rupture membranes to try to prevent cord prolapse and abruption. They don't want a sudden change in the uterine size. They want they want to gradually release it. Oligohydramnios is the opposite problem. It's when there's not enough amniotic fluid. The risk factors, it's more likely post-date, so post-maturity, because the placenta is not being perfused as well. Placental insufficiency for any other reason, preeclampsia, some drug use, smoking, things like that. Renal malformations in the fetus can actually cause this, but other than renal malformations, usually this is going to be anything that decreases placental perfusion. You can sometimes see temporary oligohydramnios with dehydration. The mom is dehydrated, it's summer, they've been out all day, their job doesn't allow them to get drinks, whatever, they're dehydrated, they have oligo. Sometimes we'll try to do a fluid bolus and see if that improves. Some potential adverse outcomes, they can have a slower labor. If it's really severe and ongoing, it can actually affect the development of the skin and skeleton. So it can cause some abnormalities in development, but it's got to be pretty severe and ongoing. It can lead to cord compression because the fluid is there as a cushion. And so if the fluid's not there, then every contraction causes cord compression or head compression. If it's chronic, there's not enough pressure when the baby makes those breathing movements inside. What's in the fetal lungs is actually lung fluid, but they need the hydrostatic pressure of the amniotic fluid to be able to make those breathing movements and increase lung development. So if there's not enough fluid chronically, they can have pulmonary hypoplasia. If it's due to placental insufficiency, like they don't have enough, the placenta is not functioning adequately, not perfusing well, it can be accompanied by IUGR, non-reassuring fetal heart tones, and meconium and amniotic fluid. Management for oligo, they get NST and BPP to monitor. They may actually do a fluid bolus to see if it improves. And then if they're severe, they induce and try to get the baby delivered. In labor, if they're having a lot of variable D cells because of cord compression, they may do an amnio infusion. Okay, we're going to move into labor in the next section. We're going to talk about the physiology of labor.